In general surgery lecture series, we will talk about spleen today. This topic is divided into two parts. First part is about spleen anatomy, investigations and trauma. And in next part, we will talk about spleenectomy in detail. So let's start. The weight of normal adult spleen is 75 to 250 grams. It is 10 cm in length, 7 cm in width and 3 cm in thickness. It lies in left hypochondrium between gastric fundus and left hemidiaphragm, with its long axis along 10th rib. The hilum of spleen sits between the stomach and kidney, and it is also related to the tail of pancreas here. The lower wall of spleen extends no further than mid-axillary line. If it goes beyond that, then it is splenomegaly. The infralateral border and lower end of spleen is notched, and you can feel these notches during palpation if splenomegaly is present. Ligaments of spleen. There are four major ligaments of spleen. Gastrosplenic ligament. It connects stomach to spleen, and it is very important ligament because it contains short gastric vessels which are important to ligate during splenectomy. Next is splenocholic ligament that connects spleen to colon. Lienorillar ligament that connects spleen to kidney, and phrenigo-splenic ligament that connects spleen to diaphragm. The blood supply of spleen comes through splenic artery. Splenic artery arises from celiac axis and it runs on the superior border of body and tail of pancreas. It also gives tributaries to pancreas. Then the splenic artery divides into inferior and superior branches. These branches further divides into segmental arteries which supply spleen. If splenic artery divides far away from splenic hilum, then it is distributive in type. If it divides near to splenic hilum, then it is magistral in type. The venous drainage of spleen goes through splenic vein. It gets its tributaries from splenic hilum and also from pancreas. Then it runs behind the pancreas and it joins superior mesenteric vein near the head of pancreas to form portal vein. The lymphatic drainage of spleen goes to celiac nodes, and the sympathetic nerve fibers run from celiac plexus to innervate splenic arterial branches. Now we will talk about investigations to diagnose spleen pathology. History is very important for diagnosis, as you all know. Then comes examination. In examination, you can palpate spleen in abdominal examination, and you can also go for general physical examination to look for the physical signs of liver damage, liver dysfunction, as liver dysfunction is associated with splenomegaly. Then in labs, you can go for CBC to look for anemia, leukopenia or thrombocytopenia, LFTs to look for liver dysfunction and clotting profile. X-rays. X-rays is not a good investigation for spleen. It only gives you incidental findings of calcification of splenic artery or aneurysms of splenic artery or any old infarcts or calcifications of spleen as in TB of spleen. Next is ultrasound. Ultrasound is very important investigation as you can look for the size of spleen, its consistency and cysts in spleen with ultrasound, and it is very cheap and easily available investigation. CT and MRI is also very important investigation as it can give you detail about the nature of splenic pathology, and you can also exclude other intra-abdominal pathologies with the help of CT and MRI. Technetium scan is very rarely used. It is used only in hemolytic anemias when spleen is destroying RBCs. Now heading towards the spleen injury. There are 5 major grades of spleen injury. If the tear is less than 1 cm and the subcapsular hematoma covers less than 10% of surface area of spleen, then it is grade 1. If the tear is 1 to 3 centimeter and the subcapsular hematoma covers 10 to 50% of surface area of spleen, then it is grade 2. Grade 3 is of two types. In first type, the tear should be more than 3 centimeter and subcapsular hematoma should cover more than 50% of surface area of spleen. In other type, the ruptured subcapsular hematoma is present or ruptured parenchymal hematoma is present. In grade 4, hilar vascular injury is present. Due to that injury, devascularization of spleen is present. If more than 25% of devascularization is present, then it is grade 4. In grade 5, we get totally shattered spleen with vascular injury, and the signs of peritonitis are also present due to bleeding in abdomen. This is the most important slide of this video. It will give you a basic approach for spleen injury management. If a patient comes to you with blunt trauma of left upper quadrant, then you need to look for surgical abdomen. If surgical abdomen is present and patient is hemodynamically stable or unstable, you have to go for surgery. What is surgical abdomen? If the tenderness is present, if rebound tenderness is present, if guarding is present, then surgical abdomen is present and you need to go for surgery of the patient. If surgical abdomen is not present but patient is hemodynamically unstable, that means patient is hypotensive, his HB is dropping, his hematocrit is dropping, then you can first give a trial of resuscitation. You can resuscitate the patient with fluid. You can go up to 2 liters of fluid and need to monitor the patient every 10 minutes. If you get good response, then you can continue the conservative management and you can conserve the spleen. But if no response, then you need to go for surgery. If patient comes with 8th, 9th or 10th rib fracture and patient is hemodynamically unstable, you can again give a trial of resuscitation. But if no response is present, you will go for exploratory laparotomy. Then if you get partial restoration of spleen and it is isolated splenic injury, you should try to preserve spleen. You can do it by the help of vicryl mesh. You can wrap the spleen in vicryl mesh, as it will give a tamponade effect and stop bleeding, and it will absorb on its own after some time, and you can save spleen with this procedure. But if the full thickness spleen injury is present and hilum injury is present, signs of peritonitis are present, then the only solution is splenectomy. Here is an interesting fact. If CT shows perisplenic hematoma and it is not actively bleeding and patient is hemodynamically stable, you should monitor patient closely and manage it conservatively. You don't need to go for surgery. If a patient comes with stab wound and you are confused, either you need to go for surgery or conservative management, then you should explore that wound under local anesthesia to see if the wound is superficial or deep. If it is deep, that means it goes beyond anterior rectus, then you need to go for surgery. Otherwise, you can go with conservative management.